On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference. My name is Susan Wallace, and I'll be your moderator for this program. This webinar is the first of a two-part series about the prevention of retained surgical items. We invite you to register for Series 2 about needles, devices, and unretrieved device fragments, or by accessing the Patient Safety Authority website. For an in-depth look about RSIs in Pennsylvania, please review the article, Retained Surgical Items, Events and Guidelines Revisited on the Authority's website. Now I'd like to introduce our speaker, Verna C. Gibbs, MD, who is a professor of surgery at UCSF and the founder and director of the National Surgical Patient Safety Project, No Thing Left Behind. Dr. Gibbs, I'll turn the program over to you.
Great, thanks, Susan. No surprise from anybody who signed up to attend this particular event that retained surgical items are a real clinical entity. And this case from 2001, where this woman had 1.5 years of pain after a colectomy performed for benign disease, was surprised to find the source of that pain was a pair of retained scissors. These problems are system issues, and as you're listening, you will see that these slides have a lot of information on them, and the content is dense. And I don't want you to get anxious about that. I want you to kind of listen. As Susan said, the material will be available to you on a slide deck, as well as the opportunity to go to the YouTube and hear my voice, but yet again. So the goal here is to try to gain some general understanding. The Swiss cheese model of Sir James Reason is often used to explain these multi-stakeholder safety events, and the primary defenders to prevent retained surgical items are surgeons whose defense is to do a wound exam, and nurses whose defense is to have some kind of management practice, often called counts. What I want you to remember from this slide is that their safety problems, and we're just going to speak about retained surgical items this morning, are problems with OR practices or communication. And just remember, practices or communication. And if you've read or experienced some of the work in this area, you might hear things like risk assessment, or there's some types of case or patients who have increased risk of retention, and that actually is incorrect thinking. It's not the patient, it's the us, it's the providers and the environments in which we work, and how our environments and each other set us up to fail. So our goal is to shape human behavior to make it easy to do the right thing right. Now, throughout this talk, I am referring to the National Quality Forum definition of when an item is considered to be retained. And you can get a quick copy of that in Susan Wallace's paper from the Pennsylvania Patient Authority. There's a whole page discussing the National Quality Forum, or NQF definition, versus the Joint Commission. But the important part of the NQF definition is that the patient has to be out of the operating or procedure room with the surgical item inside of them, and that is considered after surgery, and I completely agree with that, and actually was one of the people and groups that wrote to the NQF when they were discussing the development of that definition. So when the patient's out of the operating room, if the item is found to be inside of them, that's retained. So these are the two groups, the taxonomy. How are we going to talk about this for talking about retained surgical items? And the first group is group 1, and these 4 classes should be familiar to some of you if you're from the operating room and are familiar with the nursing practice of counting. And so surgical sponges and surgical towels, surgical means that these contain a radio-opaque marker. Those are counted. But dressing sponges, draped towels, packs, prep swabs, gauze, wound vac sponges have also been retained in various states, and depending upon your regulatory environment, those are reportable retained surgical items, but they are not counted in the operative domain. Small miscellaneous items should include also unbroken parts of instruments. Those are counted or should be, and if you're not, you should be. And sharps include needles and blades and instruments. And when we speak of a retained instrument, I mean the whole instrument. So here is a whole retained clamp. Here is the marker of a lap pad. So this is a retained sponge. This is obviously a retained needle. And this is a small miscellaneous item. This is the wing nut from a Balfour retractor. This is not the whole retractor. It's inappropriate to call this a retained instrument. This is more appropriately an unbroken piece, so it would be a small miscellaneous item. Group 2 actually is kind of everything else, used everywhere else. So retained surgical items most frequently apply to the operating room, but all procedural areas as well as ICUs and emergency departments have retained surgical items, most commonly devices. And a device is really anything that is used in medical care or practice. But the most commonly retained device are guide wires or catheters that are inadvertently left in intravascular. That's arterial or venous or interstitial spaces. But a retained device is any intact device. And if the device has parts or pieces that break, those are called unretrieved device fragments, and that's a FDA definition. And these are frequently evoked when the risk of retrieval is greater than the risk of retention. So those device fragments, or UDFs, as I'm going to call them going forward, are left in people. This is just a quick example of a device. This is a package of white OR towels. I would bet most of you don't think of this as a device, but it says really federal law restricts this device to the sale by or on the order of a physician. So devices are really anything, not just the things that have mechanical or electronic parts. And this is an example of the Group 2 retained surgical items. This is a retained guide wire. This is the whole guide wire. And this is an unretrieved device fragment, or a UDF, which you can see here is left embedded in the bone. I don't think any orthopedic surgeon would try to get that out. It's recognized, it's there, and it's just reported as a UDF. Now, I want you to listen carefully to my words here. Sponges are the most frequently retained items that cause patient harm. They're not the most frequently retained item. But because many reporting systems are harm-based, they have a lot of retained sponges in them. The most common site for retention is the abdomen or pelvis. That's kind of thought of as one cavity. And the second most common site is not the chest, which everybody thinks because it's the second biggest cavity, but it's actually the vagina. And in some series, up to 20% of retained surgical sponges actually come from OBGYN areas, both the OB-ORs where C-sections are performed and our labor and delivery or our perinatal birthing rooms. In the Pennsylvania Patient Safety Authority paper from Susan, that data is also corroborated in what's happening in Pennsylvania, where she also found that vaginal retained sponges were the second most common site, although there's no breakdown as to whether or not those come from the operating room, say after a vaginal hysterectomy, versus in the labor and delivery birthing rooms. The size of the sponge doesn't matter. If it's big or small, the point to take is if it's used, it can be retained. And they've been retained in all sizes of wounds, and it's all specialties. It's not just those cardiac surgeons. It's all specialties. And surprisingly to some, the number of sponges used during a case does not predict retention. In fact, we see that very small cases, in fact, cases where only 10 Ratex sponges used throughout the entire operation, yet there's still a sponge that's retained. And it doesn't matter whether it's an emergency or an elective case. Small miscellaneous items, devices, and UDFs are the most commonly retained items. And again, in Susan's paper, 57 cases were UDFs, and there were only 47 retained sponges by the NQF definition. So the Pennsylvania data set also supports that. We don't know anything really about how frequently needles are retained. We know, a slam dunk, hands down, every OR, every report that I've ever read or spoken with the folks that we're working with in the operating rooms, needles are the most frequently miscounted item. But we don't know how frequently they're actually retained, and instruments are very uncommonly retained, and the most commonly retained instrument is a malleable retractor, a ribbon retractor, a fish, that general category. So that's a nice segue into the first section on instruments. I'm not going to spend a lot of time. I want to give you some new work that we've been doing with centers, and this will be, it is in the policy, which you'll get at the beginning of the year. We call that a policy reference manual, a job aid. I'm only going to present new ideas or controversial ideas, confusing ideas, areas where we found a lot of abrasion to help stimulate your thinking and look at what you're doing at your centers. Certainly, you have any questions, you can send me an email, write to me. I'll be happy to work with you or try to help you sort through these. The first is, we know what an instrument is. It's a tool, but we often get this confusion. Well, we have these small miscellaneous items versus an instrument. So is a bulldog clamp, should that be counted as an instrument or a small miscellaneous item? And that makes a difference because instruments are counted on the count sheets that come up from SPD, but small miscellaneous items or SMIs are kept track on the dry erase board. And so our recommendation is, if the bulldog clamp was part of the instrument tray, is on the count sheet, then it should be counted as an instrument. But if it's added to the case for specialty use or for one moment or for something particularly that came out of peel packs, then perhaps it's best to count as an SMI, because then you're not going to have the category of that on your instrument tray. And so that will confound, it may lead to confounding the counts when you're sorting through the instruments for your instrument final count. We think that this is something that should be decided at the beginning of the tray, when at the initial count. And if an instrument, you want to keep track of it on the count sheet. So even if you add an instrument during the case, track that instrument on the count sheets, so all of the instruments are kept in one place. And if it's a small miscellaneous item, you track it on the dry erase board. What about instrument counts? When do we have to do them? Do we even have to do them on everything? And this is general work that we've been sorting through. We think that they should all be counted on abdominal and pelvic cases and all chest cases. Those are big cavity cases. Nobody seems to disagree with that. But then you've got these other whole lots of other cases. And so our recommendation is that instrument count should be performed, certainly an initial count, when an incision that is made is greater than the size of any instrument used. All of you know, experienced folks from the OR, that the size of the incision can change. The whole nature of an operation can change, which is why you should always do an initial instrument count in missed cases, since there's not any certainty of which ones may have to convert to open. And then if it turns out that nothing has changed, then you don't need to perform a final count, because you have, say, all of your incisions are smaller or the depth never changed, other variables. Some thinking around this is that in many historical policies, the specification of a size of a wound greater than 2 centimeters, then if your wound size changes, which I just said, you have not been prepared, so then you go to x-rays. And x-rays are not the solution. We don't think that x-rays are the solution. They are a problem that needs to be addressed. And we don't want the default to always be, well, we'll take an x-ray, because x-rays, one, take time. They cost some more money. And more important, or equally important, we're irradiating our patients. But after 20 years in an operating room, you're irradiating your cells. and you can't wear lead for all cases. So this nature of we'll just get an X-ray is not the solution. It's telling you if you're getting a lot of X-rays that there are problems with the management of your surgical items in the operating room. The other point about this is many policies say something that the counts will be performed in any case where there is a potential for retention to occur. Well, who's going to make that decision? You're starting a case. Who's going to say, well, what's the potential for retention? So policies should be directive. They should specify what the people that are expected to follow the policies should do. And when we say abdominal pelvic cases, we mean on the chest or abdomen, not just when they're inside the abdomen or inside the chest. And the other point to make is it's not all about counting. It's not just about the counts. The other step is that the surgeon has to perform a wound exam. We call it a methodical wound exam in all cases, in every case, and not rely only on the count, which wasn't done in this case, where it was a superficial abdominal wall hernia repair. The nurses said, we don't count since the operation wasn't in the abdominal cavity. And the surgeons were, well, the nurses told me the count was correct, so I only do a wound exam if they tell me something is missing. So both of these are incorrect perceptual awareness, and both are presenting with unsafe practices. This is what we say this is what I'm referring to when I say the methodical wound exam. It's a 3-step guideline. It should be done at the closing count, before closing any incision, a pacemaker, a superficial wound, a deep abdominal wound, not just when you're in a cavity. It's for any wound. And it's more of a mental model than an actual practice that the surgeon must think and actually look for usually it's sponges, but all of the surgical items. And there's no risk adjustment on this. It's every case, every time. In usual practice, instrument counts, there's only 2 that are done in the OR, an initial count and a final count. And actually, the final count is a process. It's not a count done at one time, because it should be started at closing. And you all know this. If you have a lot of instruments, you can't just stop and count them all at the last count. So it starts at closing and must be completed before the patient leaves the operating room. But the initial count is what's done in the OR, but the count that's done in SPD is what the initial count should be referencing. And you're doing the initial count against the information that should be transmitted on the pre-printed count sheets that come from SPD. This discrepancy between what SPD said was on the trays and what was actually on the trays at the initial count is the most frequent source of error in instrument counts. Therefore, that communication and feedback in getting the information correct between the initial count and what SPD sent up requires a different loop, which many hospitals don't necessarily close. The second most common source of instrument count errors are counting an instrument that is still in use at the final count before the instrument actually is on the back table and technically out of the patient. So you can't count as out an instrument that is actually still being used. And at the final count, all of the instruments have to be out of the patient. So you've got a lot of instruments you can go through. You know they're not going to be using those retractors. You know they're not going to be using that set of specials, so you can count those, but you can't count the needle holder that's still in the surgeon's hand, or you can't count this if it's still in the patient's wound. And this is the most commonly retained instrument. And I want you to think about that hundreds and hundreds and hundreds of instruments are used during operations, yet the most commonly retained instrument isn't a hemostat, isn't a Kelly clamp. It's this, which tells you, again, this has nothing to do with the numbers of items that are being counted. Nurses and scrubs are actually excellent counters. It has to do with the behaviors and perceptions of how they manage the items. So these cases are always the result of 2 process errors. Some kind of distraction has usually occurred, and then either no count was performed because the retractor had been an add-in, or it was counted as out when it was seen. but not really out. And this is a case of a young person who had a retractor in their body for upwards of 7 years. They were in a disabled person's institution and complained of a lot of pain, which was finally addressed. You can see this is a large malleable, and it was removed laparoscopically, which can be done because the metal does not usually cause a big reaction. Prevention strategies, you should look perhaps at safer retractors, processes that I've already discussed, how you're counting these particular types of instruments. And unfortunately for this particular case, the surgeon's performance of a wound exam may not be helpful because this retractor is used after they have begun to close. Briefly, I'm not going to spend any time on this slide just to reinforce what I said before about the relationship with SPD. SPD at the initial count, but SPD, importantly, if they find something that is returned to SPD that is broken, they have to call back to the operating room or a designated person so that they can determine whether or not that piece that's missing is actually in the patient. And there's now increased expectation for tray-to-patient accountability, not only for retained surgical items, but mostly for infection prevention. And also, I remind you that your device representatives are content experts in these loaner trays with inventory that's actually managed by the company. This is not saying the sales representatives are performing instrument counts. I'm not saying that. They're not substituting for the scrub circ responsibility, but they're another set of eyes that can provide information whether all instruments have been accounted for. And if any deficiencies are identified, the representative should notify the supervisor or the charge or the designated person immediately so that you can determine, well, where is that trial head? So alternatives to counting are a mandatory X-ray in lieu of an instrument count. This can't be just done because we want to do it that day. You have to have a specified cases where that's going to happen, and it usually happens in those that are going to have an X-ray anyway. And so if they're using fluoro, you want to make sure that an image is captured and saved and just read by a radiologist that says there were no instruments seen, and that X-ray must be taken at the closing count before the incision is closed. So you can't use the PACU construct check X-ray for your X-ray in lieu of an instrument count. The intraoperative X-ray must state that the film is being taken to review specifically for surgical instruments, because the radiologist who reviews that image has to know that that adds and forceps that he sees or she sees is not on the patient, which they may think, but it could be in the patient. And the X-rays have to include the full surgical field and report back directly to the operating room to the surgeon. The surgeon can't call his or her own X-rays negative. They have to have an external reviewer, which is the radiologist, who's the content expert. And No Thing Left Behind has some recommendations that were written by radiologists and radiology technologists for optimal X-ray understanding for finding missing surgical items. We specifically say that this is an MSI chest, which includes these types of guidelines, and these imaging guidelines can be used for all intraoperative retained surgical item detection needs. And then the last one, which is far more progressive, is don't count at all. Not everything, but instruments. And so this is a team-based process that is helpful because in some cases there are a lot of radiolucent objects used. That is, they're not X-ray detectable. And so we call this the surgeon scrub checkout, which is a wound exam done by the surgeon and a back table review done by the scrub person. And a way to look at this is the Conceptual Framework. This is a Civil War surgeon's instrument set that illustrates the principle of one item, one slot. You can see if something's missing, the scissors are gone. Here's the surgeon's hacksaw that's missing. And car repair shops and airline facilities use this to help their personnel identify if they're missing tools. That is not this. This is instruments on a stringer. That's not that, but it's this. So many of the ortho surgical supplies, Stryker, Dupree, their ortho trays are actually very well organized. I use this as the egg crate example. But you can see if you're missing a trial head. And so this is something that the scrubs have to put the dirty instruments and items back in the designated slots on the trays, and at the closing count, a hard stop. That's a hard stop. The surgeon must stop and do a wound exam. The scrub looks at the instruments that they have that are defined in trays or designated spaces. But most importantly, these incisions aren't usually very large or deep, but the surgeon does the wound exam, and the circ is also looking at information on the count sheets and trays. So this is a team-based effort, and they all agree that there's nothing in the wound. They may not have all their counts straightened out, but they know there's nothing in the wound. And if that's the case, then they can call that count correct. And if there's any discrepancy, disagreement, you can't get along, then you'll have to get an X-ray. That can't be just done. It has to be something that's thought about. Now, in the next 10 minutes, I want to run over some slides about fundamentals. This is a conceptual framework, but the important thing here, you'll see 3 X-rays. They all have a retained sponge in them. And if I just tell you that there's a retained sponge, you don't really know anything. You think you know something, but I want to show you that you don't. And so there are actually 3 kinds of, I'm going to use sponges as the example, but this applies to all retained surgical items. There are 3 types of retained surgical item case. So I'm going to say sponges from now on because I'm using sponges as an example. But there's a no count retention case, a correct count retention case, and an incorrect count retention case. And this is a case of a woman who had a vaginal birth. There was no wound exam done. There was no counting because we don't count in labor and delivery. And she had some postpartum bleeding where they put a vaginal pack in. That was removed. And the woman went home with her healthy baby. At 2 weeks, she developed a persistent discharge and a foul odor, and the obstetrician said that was normal. At 4 weeks, this persisted. Now she's got a fever and pain, and so the doctor says, well, you must have endometritis. And then at 6 weeks, she's sicker and more pain and worse, and she says, I'm going to the emergency department. And she goes to another hospital, and they take an X-ray because she's got abdominal pain, and here's a retained Raytec sponge that was used during the birth. This is not the vaginal pack. So it turns out by policy or practice, they didn't count. We don't count in perinatal birthing rooms. And about 10% of retained sponge cases are these no-count retention cases. And in Susan's paper, indeed, she has some incidents and stories that are exactly like this, these retained vaginal sponges that are taken out in the office. And these also are in cath labs and ambulatory surgery centers where everybody thinks that they don't have to count or they don't have to have a sponge management practice. And by policy, they have no counting done. This is a patient who had a lung cancer that was removed, and during the operation, the nurses did their counts and they called them correct. And before closing, the surgeon supposedly did a sweep, and this patient routinely went to the ICU after these large lung cases and had a routine post-op chest X-ray, which the doctor gets a call. There's a curved radiopaque density in the apex of the right lung. And it may surprise some of you that this is the most common scenario for a retained sponge. This is 70% of retained sponge cases occur in the setting of a correct count. And if you don't have very many, 1 case a year, I bet you it's been a correct count retention case. And these cases are practice problems because the practice of counting that was used failed to detect that there was an error. This is different. Even though the X-ray looks the same, here's a sponge in the left upper quadrant here. This was a case where they did a colostomy. It was elective, and the nurse's practice identifies that something is wrong. They say, doctor, we're missing a sponge. And then the surgeon says, well, look in the trash. Yesterday you told me you were missing a sponge, and it was in the trash. And the nurse says, well, we looked in the trash, but it's not there. We have to take an X-ray. And the surgeon, if you'll notice here, there's staples all the way down here. The surgeon says, okay, go, and then they take the X-ray. But the surgeons kept closing, and now the surgeon reads this image and says, okay, there's a stent, there's a drain, there's nothing here. This image is negative. And this hospital doesn't have radiology read back to intraoperative x-rays, and the nurses don't have a process for moving information up the chain of command. Okay, miscount, x-ray negative. And they don't have any reading of intraoperative images right away, maybe 6 hours later or 12 hours or whenever the radiologist dictates this radiopaque density because they think that everybody would know that it's there, and they file the report. Nobody picks this up until the patient is sick. So this is not about the practice here. That's a problem with communication. These stakeholders couldn't get the information exchanged between the three slices of cheese, the surgeon, the nurses, and the radiologist. And this is the more uncommon. This is about 20% of retention cases occur in the setting of an incorrect count, and these are communication problems. So those are 3 retained sponge x-rays, but they're very different. And think about that. If you're following the Joint Commission definition, you're going to have more incorrect count because they would say that if it was in the patient and discovered and removed, that that's retained. But that's why another reason why the Joint Commission definitions are unsatisfactory in my mind. And we recommend the National Quality Forum because it's cleaner. So in California, we have public reporting, and this is just an analysis to say, well, of the 79 reports that were from 5 years of just the ones that are available to the public review, there were 46 cases of retained soft goods, and of those 46 cases, 41 of them were correct count retention cases. That's 89%. And think that, what about the surgeon? Well, that means 100% of these cases had a faulty surgeon practice. Either they didn't do a sweep or they did a sweep and it was ineffective because both practices employed by the nurses and the doctors failed because they failed to detect the presence of the retained sponge. So it's a blame game when you get these groups together. The gynecologists are just quietly taking the sponges out of the vagina in the office, and they don't tell anybody about the no-count retention cases, so we don't get anything improved in that domain. The surgeons blame the nurses. They can't count because they're thinking about the correct count retention cases. They told me the count was correct, but there's a sponge left in my patient. And the nurses are blaming the surgeons. They never listened to me. I told the surgeon that there was something missing. But they're thinking about the incorrect count retention cases, which is what they remember. So no count and correct count, there's a problem with the practice. So you need to get a better practice or get a practice in the first place. And adding those numbers up, 80% in many instances, as I said before, 100% of retained sponge cases are practice problems. So if you don't have a practice, you need to get one, which is something that needs to be done in labor and delivery and birthing rooms and in cath labs where not percutaneous procedure, but where pacemakers, because pacemakers have a pocket. And if you have a practice and you've had retained sponges and they're correct count retention cases, then there's a problem with your practice. And counting just again and again the same way or adding more counts does not improve a practice. It adds complexity, and it doesn't make it simpler or more reliable. And if you just sit down and rewrite the policy or add a step, that's also unlikely to prevent recurrence. You have to examine the practice, which is likely error-prone, meaning you can't detect error and non-verifiable, and many think, well, we'll get a new technology adjunct. There's two, one that counts and one that's able to detect, but these are not new slices of cheese. These are not new defenses. They're just additional holes, more complexity in the slices of cheese in whoever is using the device. So the surgeon can use the detection system either at the closing count, or some surgeons refuse to do that, which is indeed problematic, and they rely on the nurses to do it at the end of the operation. Or a counting device, but that's a new slice of cheese. It's not a new slice of cheese. It's just more holes in the human's already complex cheese slices. So a little specificity for the actual issues that we're seeing out there in soft goods. This is a practice. It's called the Sponge Accounting System practice. It's a standardized manual way to manage sponges. It has some high reliability principles associated with it. You can look at it up on the website, the Nothing Left Behind website, which will be, I'm revising it, so it'll be back up on Monday. But this is longstanding. Hundreds of hospitals around the country use it. It has communication strategies that help the humans talk and work with each other, and it has defined practices. And the defined 10-step nursing practice, you have to use these blue-backed plastic sponge holders in a defined way. You can't just put the sponges in any way you want. You work in one multiple of 10, and always multiples of 10 for laps and for RATEC. There's a pack of laps behind here, and you work with a 10-pocket configuration, which is completely approved and within the information or instructions for use from all of the sponge counter manufacturers. If you have 5 empty pockets, is that 5 retained lap pads? Which you'd say, that's never happened to me. And then I would say, you've just been lucky, because this is not because the people who were working that case weren't counting. They were counting, and probably counting something like this in the unit of issue, 5 plus 5 plus 5 plus 5. And if you think about it, it's easier to leave 5 lap pads with that system than it is to leave 2, 3, or 4. But the sponge accounting system, all counts are written in a running total format, and there are only one multiple, 10. So the counts for the RATEC and the laps are 10, 20, 30, 40, just like you write needle counts. And this also tells you that you have 40 lap pads out, so you should have 4 holders, only 4 holders, hanging up there with all of the sponges in the pockets, so you should have no empty pockets, which is the meaning of a correct final count. And then there's some communication strategies. We try to reach your brains through a mantra of what to do for the initial or at the in counts, which is only 10s, and speaking up at the closing count so that the surgeon can do a wound exam, which you might have to remind them, hey, doc, don't forget to do your wound exam before you pass closing suture. But most importantly, at the final count, we're all in, and the sponges are all in the pockets of the holders. And then the circulating nurse has to show somebody else that there are no empty pockets. So if you're missing something, you need a communication strategy. And so here's a tool to help the stakeholders, which are nurses and surgeons, get the steps correct so that we don't rely on memory. And we want this up as a sign in the OR, laminated against the wall, because the stakeholders can't get to their handheld, nor should they. And it helps them know when to bring in the third stakeholder, or third defender, our colleagues in the X-ray department. And if we don't find the sponge, we've got a problem. And you push the purple button, make sure you tell the surgeon, we never found that lap pad. You move it up the chain of command. You get the information to the administration, and the surgeon has to have a conversation with the patient, and we've got to do something else to make sure that the sponge is not in the patient. So I just have one slide on towel management, because these also are retained. I refresh your memory that OR towels are 2 versions. There's surgical towels, which are white. We want them in white, and they contain a radio-opaque marker. They have them in other colors, but you only want to buy white surgical towels with a radio-opaque marker. And these are the towels that if a surgeon wants to use something intracorporeally, they would have a package open. You count the package right on the dry erase board, and you count these. The blue, green, unbleached drape towels are of a coarser grade of cotton, but they don't have radio opaque. They shouldn't. They have them on the market, but you shouldn't buy them, because you don't want to have the drape towels, which you're using to drape the field, have markers on them, because then the markers, if you have to take an X-ray, will confound the X-ray image interpretation. And our drape towels are like the workhorse in the operating room. We use them for everything, to wipe hands, on retractors, a skin protector. That's not in the patient. That's on the surface under the retractor blade. They travel with specimens. I've not read any retained towel case where the towel accidentally slipped in. That doesn't happen. The surgeon puts the towel in, and the towel either has been taken or given to him or her by the scrub person. So let's be honest and be real about this. If you have surgeons that use surgical towels, You're not going to win the battle trying to convince them not to use them, so get safe towels. Get towels that have a radio-opaque marker that's white. And this makes it easy for the scrub person. You count the white. You don't count the blue. If there's a white radio-opaque towel, you should be able to see the marker on X-ray. So then lastly, very quickly, I've got 5 minutes, which will be just about right, is packing. And so interestingly enough, in Susan's paper, there were 1,145 reports that were reviewed. These reports are a big mishmash of stuff that you guys out there in Pennsylvania have been sending in. But if you look at the results of that, 85%, it was actually 83.8, which is closer to 84, but that's 85%. 85%, which is a big majority of those reports were actually about therapeutic packing, and those were just excluded. And I don't know why Pennsylvania is requiring them to be reported in the first place, but I won't criticize that because we don't consider that retention. Not we, nobody does. These aren't retained. These are intentional. This is therapy. We're doing this, putting the sponges in people to solve a problem. It's not inadvertent. So that terminology should be therapeutic packing, which is what AORN also uses, and we use it, and it's a conceptual framework. If you're therapeutic packing, it's not retention. You can leave a retained sponge after you did this practice, but that's separate. That's not just the action and you get everything out. So recommendations to clarify this, this is just a table. I wanted to try to help you think through the differences between this because the word packing seems to be applied to everything. But we strongly recommend that you use lap pads. Don't think of something strange. It's not a good idea to use towels. It's not a good idea to use the St. Mary's sponge. You want to use lap pads because they're ubiquitous. You've got them in all of your ORs. They have a well-defined marker. Radiologists can get that marker. If you use a towel, the markers are smaller and thinner, depending upon your product. But this is also an item that's been counted. And so we want you to use the sponge accounting practice so that you will now have all of your sponges at the end of the case in your sponge holders, so you'll have empty pockets. And by definition, that's an incorrect final count. By any time you have an incorrect final count, you have to move that information up the chain of command. So you tell your OR manager, hey, we put packs in this patient. We think they're 5 or they're 2 or however many. That's less important. But you've moved the information so that the OR manager then talks with the surgeon. When you're bringing this patient back, you're ready for when this patient is brought back because you know they've got packs in. And you follow the MSI protocol for x-rays at the closing count, no matter whatever you think you got all the 4 that were put in 2 days ago when it was a different nurse or different team. At the closing count before the definitive closure, there should be a set of x-rays obtained, and you know what the radiologists are looking for. They're looking for lap pads. Now, on the other end of the spectrum here under wound packing, that's dressings. That's just wound care. That is a contaminated wound with dressings placed in for wet to dry dressings, a nosebleed. These are managed by doctors writing an order, nursing, or the patient following the orders. And yes, there are cases of wound vac sponges, but this is not counted, and it doesn't really involve too much the domain of the circulating nurse. This, however, orifice packing, and the biggest problematic area is the vagina. And vaginal packing, we have a few cases of packing left high in the nose, nasal sinus, but the vagina is the problem. It's not a problem. The vagina is fabulous. It's not the vagina that's the problem. It's us in managing the sponges and material that we put in the vagina. And this is frequently retained. The packing is not a dressing, so it's not counted, and it's removed over a handoff, which usually takes place in the PACU, or it could be in the patient for a day, depending upon the physician's orders. So you need a tool, because this is a communication problem. And so we've designed, and many, many hospitals use this. It's hard, but communication problems are hard. And so in the operating room, the circulating nurse gets the pack and gives it to the surgeon, And then we have something we call the packer tracker. And right now it's in paper format, but many hospitals have moved a version of it to, if they're on Cerner, to the domains of care that are involved there. And then we need a tool to help the patient, help us get it out, because we can't seem to get this pack out just between the doctors and the nurses, because the circulating nurse was present when it was put in, but it's removed at another handoff, maybe 2 or 3 handoffs later. So generally, you want to use vaginal packing that always has a radio-opaque marker. Don't put iodoform gauze in the vagina. I know that a lot of the OBGYN guys do, but that stuff can be moved up into the upper portions of the vagina. Everybody thinks it's going to be discovered. You want to put something radio-opaque, and the best is a marker that runs throughout the interstices of the gauze or is present throughout the pack. So if when the surgeon cuts it to fix, which is fine, dressings can be cut, they know that there's a radio-opaque marker. And then we have a band, an armband, that should be something that is compliant with your armband that basically says packing in place. It doesn't say where it is, but it's in place. And the idea here is that you have a kit in the operating room where you have your packer tracker, you have the pack, and you have the band all together. And when the surgeon or obstetrician says, I want some packing for the vagina, you get your kit, you put the packing in, you start your packer tracker, you put the armband on the patient, and then as the patient moves over these handoffs, the nurses are tracking it. And when the order says remove the packing, then the nurse has to make sure that the armband is removed and what was put in matches exactly what was taken out. Any discrepancy, you get an X-ray, and since you've got a radio-opaque marker in your packing, the X-ray will show. The other soft goods to make note of, and I'm finishing, Susan, is the quick clot hemostatic dressings. These are usually seen in trauma situations, but we see now people coming in with this stuff in the ED. They can get it on Amazon. And some of it has radio-opaque markers, some of it doesn't, but bikers and hikers, they put it in their backpacks, and if they fall or have an injury. So the trauma pad is seen in the ORs used by trauma centers. These must be removed. They must be removed by 24 hours, so they can be used in the therapeutic packing domain, or they could be used in wound packing in the tractotomy. If there's bleeding tract, the surgeon puts in the Z dressing and then writes an order, remove or change dressing, but that has to be removed within 24 hours. So I close with a case, very short case, of a woman who had a breast biopsy, and she had cancer on that biopsy, and she was taken back on a Monday morning to have, this is not my case. Everybody thinks it's my case. It's not my case. It's just one of the earliest cases in this project which I started this work on. And she had a cancer, and so they took her on Monday to have a node dissection, axillary node dissection. And there were 10 Raytech used in the case. They called the counts correct. There was no problems. The whole thing took about an hour. And the woman was seen in the office on Friday, and she had a little drainage coming from her axillary incision. And the surgeon opened the incision and pulled out a Raytech sponge. And on Monday, everybody was brought together for the RCA, which was done with all hands on deck at this particular hospital. And everybody was asked, you know, what happened? Where were you? Did you use this practice? Because we were introducing the sponge accounting system. And we couldn't get too much when we had everybody together, so we just broke up that RCA and then did individual interviewing. And so one of the questions was to the circulating nurse, well, did you put all the sponges in the pockets of the holders? And the circ said, well, no. And so we asked, why didn't you put all the sponges in the pockets? And the circ said, well, because I didn't have to. Not in an insolent way, not in a defiant way, because I didn't have to, as in no one made me do it, like the sponge police weren't there. No, it was more as in I know how to count 10 Raytech, and I didn't need to use those counters to do it. See, I know how to count 10, and I don't need to put the sponges in the pockets of that sponge holder like you taught us, like we're supposed to be doing, because I know how to count. But you're missing the point. because, yes, you do. You do have to use the holders, even if they're only 10 sponges, because we know that you know how to count. You're not using the holders to count. You're using the holders to prove where the sponges are. Because if all of the sponges are in the pockets of the holders, they can't be left in our patients. And that is how we can work together to make sure there is no thing left behind. Susan, I am finished. Yes. I will turn this over to you.
All right. Thank you very much, Dr. Gibbs. And that concludes the slide presentation portion of our program. But we would like to begin our question and answer period now. So while we're waiting, I do have a question for you, Dr. Gibbs. I saw in the last slide that it said, or I think it said AORN agrees. And where is ARON on these recommended practices you have discussed with us today?
Yeah, so I have tremendous respect, work with AORN, and am really honored and pleased as we've crossed paths. AORN focuses on nurses, and you can see, I hope, in this work that we've been doing that we're working on multi-stakeholder. We want surgeons and radiologists, and we even have guidelines and recommendations for anesthesiologists, which AORN encourages, but obviously doesn't have any jurisdiction over. And specifically, AORN previously had counting out of kick buckets as kind of the standard, and I'm really happy to see in 2016, if you aren't, the audience is not familiar with this, they actually began endorsement, not mandatory, but again, it's within their recommended practices to use a pocketed sponge system, which is exactly the hanging sponge counter bags or sponge holders, as I call them. And I just have a quick little slide here. Everybody gets upset because they think that the manufacturer, IFU, don't support the use of the 10 sponges per holder for lap pads. And then I've just taken 3 of the distributors, and they all say 10 soiled sponges may be placed. And for but it's may be placed, may. This isn't must. The manufacturers can't order you one way or the other. The plastic holders do not burst. They are designed, and the lap sponges are able to be used in 5s if that's what your practice or your policy says. But you can easily put 10 soiled sponges. Lap pads are just sponges, and as many of you know, lap pads come in many different sizes. So small 4 by 18 and 18 by 18 lap pads fit very nicely in the pockets, and 10 sponges is perfectly authorized, and it's within the instructions for use. If you're counting in 5s and 10s, then you probably want to pop the center divider. But if you're following the sponge accounting practice, you've got to work only in multiples of 10, at least up for the laps that are most commonly used, the standard laps. If you're a trauma center and you're using a towel or you're using supersized sponges, then either in plastic bags or popping the center divider, but then you're not counting in 10s. You might be in the unit of issue. Some of them come in 1s. Towels come in 2, 4, 6. That's outside of the realm. It's in the policy, and there's recommendations for that, but that's not what we're speaking to for standard practice. So AORN is doing a great job. We're all trying to solve the same problem.
Okay. Early in your presentation, when you were talking about SPD, there was a question that came in, and it was, the question was, I thought it was no longer acceptable practice to place a count sheet from SPD in an instrument tray due to the potential of contamination. Is this not correct?
So I've heard that a lot. It depends upon how the count sheet is put in the instrument tray. And the issue that I understand around that was around ink, and the ink wasn't water or steam sterilizable, and ink was bleeding onto instruments. So most institutions, yes, absolutely, have SPD completing the count tray, and then they put the count sheet in either a paper bag or a separate autoclave acceptable pouch, and the first layer of the trays have the paper, and the count sheet is placed on the sheet on top of the first layer of the multiple bundling of the sterile processing process for wrapping or managing the trays. As you know, the count sheet is not, it's used by the circulating nurse, so the scrub person who maintains sterility does not touch that, or doesn't have to touch it during the time of the operation. But the way that the count sheets are put on each tray are placed in a separate, the ones I've seen have been paper bags, to be truthful, but I understand that there are these autoclave special types of pouches that can be used. Also, a lot of systems are moving to an impress management system where they also have the count sheets that are completed electronically, but they must be in the OR with the circ in hand in order to do the initial count.
Okay. We do have another question. Do you have a count audit form that you recommend that can be used to audit counting at each site?
So I don't consider counting as the methodology. I do not recommend counting in the unit of issue with the 10s and the 5s and the 10 plus 10 plus 10 and 5 plus 5 plus 5, which I believe may be what the questioner is asking about count sheets. If you are using the sponge accounting system practice, there are audit tools which are part of your practice when you're learning it and you're setting it up and instituting it in your operating space or hospital or system. And then there are audit tools that you can use that we call them competency assessments that are used on a routine basis throughout your work. And those are on the website. They aren't there right today. As I said, there's a lot of stuff that is being, I've revised. You've seen the most recent versions of the handouts, and I just blew up my website putting everything up there, so I have to fix it. But anyway, they'll all be up there on Monday. There's audit tools. There's all kinds of things that you can use to help assess and manage the practice. But I have no comments, aids, or help specifically about counting. But if you are using the sponge accounting system, there are audit tools that can help you assess the work that your scrubs and circs are doing in the OR.
Okay. We're just going to read one last question, Dr. Gibbs, and it's, do you use counted sponges to prep?
It's an interesting question. Okay, so if you're asking me personally, I can't answer that because that's irrelevant what I personally do. But is that part of a recommended practice? So I'm going to go to the labor and delivery birthing rooms. They have been very resistant in using a sponge management practice because the perinatal birthing areas don't think they have a problem, but they have a problem. And Susan's paper tells you that they have a problem. An AORN equivalent in the ACOG or AMWA, which is the OB world of nursing, they just gave it's called the Women's Patient Safety Organization or Group. They just had a big webinar in like February or March saying to birthing rooms, you guys have to get a management practice in there because there's too many retained vaginal sponges happening to our mothers. So one of the practices that we recommend is use the sponge accounting practice. So you have 10 pockets, and we like the baby laps, which are 4 by 18 laps. They're a lap pad, so it's bigger and doesn't stick together like the Raytec. If there's any experienced nurses on the call, you know how you hate those Raytec because they're hard to work with. And these baby laps, they're also called, they use them in lung cases. It's just the 4 by 18 lap pad. But it's really good for the L&D rooms because it gives them something more to work with. And so to answer the questioner, the way that I see that practice evolving is the nurses use a prep. Some do. Some birthing centers don't. They use green soap or betadine. But you use 2 of those sponges or 3 of them to do the prep and put them in the pockets. And then during a birth, you may not have any, maybe 2, 3, 4 sponges you may need. Sometimes they don't use any sponges in a birth. And then you have 2, so there's 4 plus the 3 you used for the prep, and then there's 4, and now you've got 3 more, and you use those to dry off the perineum after the obstetrician has done their episiotomy repair, or maybe not. You just have 3 nice soft sponges to clean up. Now you've got 10 baby laps in the pockets of your holders, and you have a correct final count, and you know that you haven't left one of those baby laps in mom. In the OR, no, we do not use prep sponges to prep cases. We use prep kits, and I think that's become an industry standard, although I know that there are a lot of places that still use them a counted sponge. I think that's a bad practice. You want to keep your counted sponges on the back table under the control of the scrub person. That's their responsibility, and use prep kits. But, of course, now we have cases of retained prep swabs, so that's a whole other problem.
All right. Well, thank you, Dr. Gibbs. And I want to thank everyone for joining us today. And this concludes our webinar.
Come back next month and we'll cover needles and small miscellaneous items and devices. Thanks, everybody.
Thank you.